আমি একটা কেস সিনারিও বলবো।
বলেন স্যার।
একটা 40 years old male, non-diabetic, non-hypertensive, but a smoker, presented with large HD secondum, 35, 28, 32, 35 millimeter, with deficient posterior inferior rim, and with MR grade 2 due to MVP. I searched for cleft, but I did not. And his oxygen saturation resting stayed at 95%. But he is on NYHA class 2 to 3. Cardiac cath done before 3 years before. PVR was 2.07 wood unit. Now the blood pressure is now 120/70 systemic pressure. Our PSP was 85 and PADP was 37. So whether we should go for another catheterization or and then what we should do, surgery versus device closure.
স্যার কঠিন সিনারিও স্যার, 3 বছর এখন স্যার এক্সরে দেখে যদি মনে হয়
এক্সরেতে কার্ডিওমেগালি আছে বাট সিগনিফিকেন্ট প্লেথোরা নাই, মানে লেটার 1/3 যেটা সেটাতে একটু অলিগেমি আছে, পালমোনারি কোনাস ইজ ফুল অ্যাজ বিকজ এমআর আছে তার, সেই জন্য বাইভেন্ট্রিকুলার এনলার্জমেন্ট আছে তার।
স্যার আমরা তো এরকম এত পিএ প্রেসার এত ইয়েতে তো আমরা সাধারণত করি না স্যার, আমরা মেডিকেল থেরাপিতেই থাকি।
আচ্ছা, নারুবা কিছু বলছে।
হ্যাঁ, পিভিআরটা কতটুকু স্যার?
পিভিআর 3 years before it was 2.07 would you mean?
হ্যালো
স্যার শেয়ার করব।
হ্যাঁ
স্যার এই পেশেন্টটা যেহেতু 40 ইয়ার্স নন ডায়াবেটিক, তারপরেও স্যার তার অ্যাকোয়ার্ড কোনো হার্ট ডিজিজ আছে কিনা, এলভি অ্যাকোয়ার্ড মানে আমি যেটা বলতে যাচ্ছি যে করোনারি ডিজিজ আছে কিনা, এলভি ডিসফাংশন আছে কিনা, এলভি ইডিপি বেশি কিনা। এই জন্য এই পেশেন্ট গুলোর অবশ্যই কার্ডিয়াক ক্যাথ করতে হয় স্যার। যদি ইনফিরিয়র
আগের ধারণা
না স্যার, যদি আপনার ইনফিরিয়র রিম অ্যাবসেন্ট থাকে ইনফ্রাপোস্টেরিয়র রিম, তখন অনেক সময় যদি ডিভাইস বসানো না যায় তাহলে বেলুন দিয়ে অক্লুড করে এলভিইডিপি দেখতে হবে। এলভিইডিপি যদি রেইজ করে যায় বা ওই ডিভাইস করার পরে যদি পিএ প্রেসার কমে তাহলে জি স্যার।
that is you are in favor of
না স্যার, আমি ট্রায়াল বলিনি, আমি বলেছি
ক্লোজার স্যার অ্যাজ এ হোল,
ক্লোজারের জন্য যে এই ডিটেক্টরটাকে ক্লোজ করে পিএ প্রেসারটাকে ড্রপ ডাউন করে কিনা, এলভি ইডিপি কি রেইজ করে কিনা, যেহেতু
বেলুন অক্লুশন টেস্ট,
জি বেলুন অক্লুশন টেস্ট করে তারপরে পিভিআর কে ক্যালকুলেশন করা, এলভি ইডিপি দেখা, তারপরে আমাদেরকে ডিসিশনে আসতে হবে। আর এই যে কার্ডিওমেগালিটা তো স্যার এমআর গ্রেড 2 বা 3, এই কারণে স্যার কার্ডিওমেগালি, এটা মানে শুধু যে হার্ট এসডির জন্য তাও নাও হতে পারে।
ভেরি গুড। অমিতাভ কিছু বলবেন?
স্যার মানে 3 বছর আগে তো ওনার বয়স, এখন যখন 40 হয়েছে, we have to find out that whether there is existing coronary artery disease, এটা প্রথম জিনিস আমরা করি। আর আরেকবার ক্যাথ অবশ্যই করা উচিত, করে আমরা দেখতে পারি যদি এখনো দেখা যায় যে পিভিআর এখনো অ্যাকসেপ্টেবল রেঞ্জে আছে, দেন উই শুড ডু মানে ইফ এট অল উই ক্লোজ, either we do a fenestrated surgical closure or a fenestrated device closure.
রাইট স্যার। আমরা মনে হয় নাজির স্যার, আমরা মনে হয় আসলে শুরু করি একটু। নুরুল আফসার আমরা শুরু করব স্যারকে সিগন্যাল দিয়ে।
অলরেডি স্যার আমি প্রিপারেশন নিচ্ছি স্যার। হ্যাঁ 10 মিনিট হয়ে গেছে তাই না?
ম্যাডাম শুরু করব।
হ্যাঁ
থ্যাংক ইউ
স্যার, একটু ওয়েট করেন, নুরুল আফসার সিগন্যাল দিলে শুরু করেন স্যার। তাহলে জেসমিন আগে।
সো বেস্ট অফ লাক সবাইরে, ইনশাআল্লাহ অনেক ভালো হবে।
থ্যাংক ইউ ম্যাডাম।
থ্যাংক ইউ ম্যাডাম।
নুরুন্নাহার ম্যাডাম আসেনি না?
উনি স্যার আগে জানাইছেন যে উনি 2 দিন আগে জানাইছেন যে উনি আসতে পারবেন না।
আসতে পারবে না?
না স্যার। আর আব্দুল্লাহ শাহরিয়ার তো ফোন ধরতেছে না। কলিম ভাই একটু দেখেন না পান কিনা ফোনে।
শাহরিয়ার মনে হয় ক্যাথ ল্যাবে আছে।
উনি ক্যাথ ল্যাবে আছে, জয়েন করবে এখনই, বের হইছে ক্যাথ ল্যাব থেকে, বলো কিছুক্ষণের মধ্যে জয়েন করবে।
স্যার আমরা এখন শুরু করতে পারি।
ঠিক আছে,
স্যার আমরা এখন শুরু করতে পারি।
ওকে, থ্যাংক ইউ। এটা কি স্ক্রিন শেয়ারে যাব?
জি স্যার, আপনি এমনি কথা বললে হবে, যদি কিছু দেখাতে চান স্ক্রিন শেয়ারে যেতে পারেন।
আচ্ছা, নাই, আমি দেখতে পাবো। ওকে, আসসালামু আলাইকুম, গুড ইভিনিং, ওয়েলকাম everyone. Thank you for joining us today. First of all, I introduce myself. I am Dr. Nazir Ahmed, Professor of Cardiology, National Heart Foundation. Today our topic is experience with the device in Bangladesh for congenital heart disease. Today's topic is divided in two components: expert panelists. 4 panelists out of 4, 3 are present here, and 4 speakers. And the panelists are Professor Dr. Jahid Hussain, Professor and Head of Department of Cardiology and Pro VC Research and Development, BSMMU, Dhaka. And next one is Professor ABM Abdul Salam, ex-Professor NICVD, now Senior Consultant, Pediatric Cardiology, Square Hospital, Dhaka. And Dr. Abdullah Shahriar, Associate Professor and Head of Department of Pediatric Cardiology, NICVD, Dhaka. Now, and 4 speakers are Dr. Jasmine Hussain, Assistant Professor, Dr. Naharuma IB Haidar Chaudhary, Assistant Professor of National Heart Foundation Hospital, and Dr. Tawfiq Shahriar Haq, Associate Professor of Cardiology, both the pediatric and the adult cardiology. And our special guest speaker from abroad, that is from Kolkata, Dr. Amitabh Chattopadhyay, Head of Department of Pediatric Cardiology, Narayana Super Specialty Hospital, Kolkata. Do you hear me?
Yes, sir.
Yes,
Yes,
great.
sir. No, sir.
Great. Just
Very much.
starting with the speakers, I like to invite Dr. Jasmine Hussain for his congenital heart disease diagnosis and general care. Dr. Jasmine.
Thank you, sir. Assalamu alaikum. Welcome to all today's special webinar. I, Dr. Jasmine Hussain, Assistant Professor, National Heart Foundation and Research Institute. Today I would like to share with you congenital heart disease, diagnosis and general care. We all know that last 3 months our respected teachers took the class for individual congenital heart disease, and they teach us in details physical examination and diagnosis by echo, ECG, X-ray. So today I would not going in details for diagnosis, just give an overview for congenital heart disease and general care. So when this type of baby come with in our OPD, this baby has a respiratory distress, tachypnea, tachycardia. We always think about this is a pneumonia or bronchiolitis, but does this child have a heart disease? So the baby have a heart disease. The New York Heart Association gives us some classification on criteria for heart disease with and heart failure, like sorry, this slide is not opening, but I want to say that New York Heart Association gives us the criteria heart disease with heart failure criteria, like no limitation of heart disease, no limitation of physical activity. This is a class 1. If patient has a limitation of activity like develop tachypnea or dyspnea during moderate exercise, this is class 2. And if patient has a daily activity, during daily activity develop palpitation, dyspnea, this is class 3, and unable to do any physical activity, this is class 4. On the other hand, the Ross, who gives us for infant, same criteria for that heart failure classification. If mother said that this baby is asymptomatic, so this is class 1. If mother said that during breastfeeding, baby developed tachypnea, because we know that breastfeeding is a strenuous exercise for the children. This is class 2. If mother said that not only marked tachypnea during feeding, also my baby is not growing well, this is class 3. And if this type of baby who come with us on rest, there is a tachypnea, retraction, so this is class 4. If the patient has this type of heart failure symptom, we should look for some criteria. This is called Nada's criteria. This have some major or criteria like systolic murmur on auscultation. If we find that grade 3 or more intensity, that indicate heart disease. If patient have a diastolic murmur, that also indicate heart disease. If patient has central cyanosis, saturation below 95%, that indicate, and also the congestive heart failure. There are some minor criteria like systolic murmur. If we find that grade 2 or less intensity, it can be, because we know that some innocent murmur also the criteria, this is systolic murmur, and usually grade intensity is 2, and is associated, patient have a fever or anemia, that hyperdynamic circulation, that also developed systolic murmur. But second heart sound, if we carefully auscultate second heart sound, and if we find that abnormal second heart sound, that indicate heart disease. If we do the ECG and if we found that chamber hypertrophy, that also indicate. If we do the chest X-ray, there is a cardiomegaly or plethoric lung field or normal cardiothoracic ratio, but oligemic lung field, that also indicate. If we measure the blood pressure, if we find that blood pressure is low, hypotension or upper limb lower limb discrepancy, that also indicate that heart disease. So if we that heart failure symptom with the presence of one major or two minor criteria, that suggest presence of heart disease. If it is not mixed with this criteria, so we should reevaluate this patient after 3 to 6 months. Sorry. But if we meet that criteria, match this criteria, it suggests heart disease. But is it congenital heart disease? For this, if this recognition in early age, if murmur is more parasternally, if the presence of central cyanosis or presence of extra cardiac anomalies, we know that some syndrome like Down syndrome, Turner syndrome, Edwards syndrome, or Holt-Oram syndrome always associated with congenital heart disease. If there is a history of fever or joint pain or murmur is more in apical, that suggests acquired heart disease, most likely rheumatic fever. So for congenital heart disease, in broad classification, we can divide this as two groups: acyanotic, when at the saturation is near normal, and cyanotic heart disease, where saturation is below normal. In acyanotic heart disease, when saturation is normal, that also we subdivided into two groups: normal saturation but increased pulmonary blood flow, means pulmonary overcirculation. Usually, when patient with acyanotic with pulmonary overcirculation, usually the disease is ventricular septal defect, patent ductus arteriosus, atrioventricular septal defect, aortopulmonary window, or atrial septal defect. In case of acyanotic but normal, sometimes slightly decreased pulmonary blood flow, usually obstructive lesion. It can be left-sided obstruction like aortic stenosis or coarctation of aorta, or on the other hand, it can be right-sided obstruction lesion like isolated pulmonary stenosis. When patient have an acyanotic with pulmonary overcirculation, this type of disease usually come with symptom like features of congestive heart failure, when this is hemodynamically significant and disease, and features of always congestive heart failure, patient always associated with failure to thrive. If we do the chest X-ray, we can find that cardiomegaly and plethoric lung field. If we do that ECG, then we can find that axis deviation or chamber hypertrophy. In case of acyanotic and obstructive lesion like aortic stenosis, coarctation of aorta, if we measure the blood pressure in aortic stenosis, we can get poor or blood pressure like hypotension, or in case of coarctation of aorta, upper limb and lower limb blood pressure can be discrepant. In case of right-sided obstructive lesion like pulmonary stenosis, patient is acyanotic, usually patient blood pressure is normal, chest finding is normal. On auscultation, we can find that ejection systolic murmur more than 2. In the cyanotic heart disease, when the patient saturation is below normal, that we can divide it in two groups. Increased pulmonary blood flow. What does it mean? Because cyanosis, but patient's lungs flooded, lungs over circulation. Usually, this case is total anomalous pulmonary venous connection, truncus arteriosus, transposition of the great arteries. And when patient is a cyanotic heart disease, but pulmonary overcirculation, usually these patients, cyanosis not so apparent because of pulmonary overcirculation, or cyanosis usually saturation more than 80% to below 95%, and symptom features suggestive of congestive heart failure. But cyanotic heart disease with decreased pulmonary blood flow, usually the disease is tetralogy of Fallot or tricuspid atresia. When the decreased pulmonary blood flow, this cyanosis is more progressive, and we can find that marked cyanosis, pan-digital clubbing, and also the history of hypoxic spell. So in a nutshell, we can say that if there is a symptom, if we look for Nada's criteria, if it is match, then is it congenital heart disease? We can divide it into acyanotic and cyanotic. Again, acyanotic heart disease can be divided into pulmonary overcirculation, normal blood flow, usually pulmonary overcirculation, left to right shunt lesion on like ASD, VSD, PDA, AV canal defect, or aortopulmonary window, or acyanotic with normal pulmonary blood flow, usually obstructive lesion like left-sided obstruction, coarctation of aorta, and aortic stenosis. Same thing, cyanotic heart disease with increased pulmonary blood flow, TGA, TAPBC, and truncus arteriosus, decreased pulmonary blood flow, tetralogy of Fallot, and tricuspid atresia. So what about the general care for these children? Today I want to emphasize their development, nutrition, immunization, infective endocarditis prophylaxis, and physical activity. So, development, growth and development, if it is hemodynamically significant heart disease, if it is hemodynamically significant heart disease, growth and development always can be hampered. Sorry, sir. As like a Amitav sir, my computer also now giving me trouble.
These are all large files. So sometimes they hang up. Very
Sir.
common. Sometimes they hang up.
Is it visible? This is a slide is small, but is it visible?
It's okay. You can go on.
Okay, sir. So growth can be hampered. And for growth monitoring, we have to close monitor the growth parameter like weight, height, and head circumference. Why? Because of ensure optimal growth and development to determine the time for further intervention. However, any flattening of the growth curve is an indication to intervention. And gross motor development, usually congestive heart failure patient and more progressive cyanotic heart disease patient have a gross motor delay, like sitting, walking delay due to adapting their behavior to conserve their energy store. But they catch up quickly once they have undergone surgical or intervention or correction. Neurodevelopmental testing score are frequently within normal range, but if the patient, very few patient, this patient has a syndromic child or congenital heart disease with a very complex congenital heart disease that need neonatal open heart surgery, that patient can develop neurodevelopmental delay. Usually risk for attention disorder, IQ performance discrepancy, visual motor integration problem, and psychosocial maladjustment. And feeding and nutrition, feeding as healthy children, nutrition should be 120 to 150 kilocalorie per kg per day. If we find in neonatal period, breastfeeding should be encouraged as long as infant is gaining weight. We should measure volume of feed, frequency of feed, and estimated the calorie intake. If feed is not gaining weight, so we can fortify the feed also. I want to emphasize this slide, immunization, like patient with congenital heart disease should maintain the recommended immunization schedule, and also recommendation is the children with congenital heart disease should receive additional immunization such as influenza and pneumococcal vaccine. Here I mention the name of Professor Fazila Madam. She always emphasizes for vaccination of this is two vaccine, influenza and pneumococcal vaccine in winter season, because this time respiratory tract infection is more common, and children and along with adult also more suffer, morbidity and mortality is more. Some children who has a syndrome like Diger syndrome, or most of the time associated with tetralogy of Fallot or truncus arteriosus. In case of Diger syndrome, there is a aplasia or hypoplastic thymus or parathyroid, and another group of patients like heterotaxis syndrome, where the abnormal distribution of the major visceral organ within the chest and abdomen. That patient also absence of spleen can be occur, or multiple spleen but functionally inactive spleen. A both group of patient has immune deficiency and increased risk of infection. So in this group of patient, we should advise antibiotic prophylaxis and also give vaccination, meningococcal vaccine or pneumococcal vaccine. Infective endocarditis, very important for our context. Dental care is very needed, like regular brushing, flossing, and visit to dentist starting at a year of age to reduce incidence of bacteremia. And administration of prophylactic antibiotic is recommended for select highest risk group. And physical activity, if it is hemodynamically insignificant heart disease, child can do physical activity as healthy children, but patients with congenital heart disease have lower level of daily physical activity and higher prevalence of obesity and other cardiovascular risks. So AHA recommended a combination of moderate to vigorous physical activity, both children and adult. But if patient associated with some disease, we should intensify their level of activity, like patient congenital heart disease with ventricular dysfunction or significant outflow tract obstruction or significant pulmonary hypertension or arrhythmia. That time we should be care about this thing. And if during exercise, if patient develop the syncope, chest pain, palpitation, dizziness, this is the red flag symptom, would reevaluate this patient again and again. So thank you. This is one of our child. You can see that before operation, the baby is very wasted, but after operation, she catch up her growth and development. Thank you, sir. Thank you, sir. Sorry, sir, for disturbance.
Okay, thank you very much for your brilliant presentation.
Yes, ma'am.
Yes, sir.
প্রাথমিক স্লাইডগুলো আমরা দেখি নাই, আপনার বাচ্চাদের যে NYHF ক্লাসটা করলেন,
জি স্যার, হঠাৎ করে বুঝতে পারলাম।
হ্যাঁ, ওটা আমাদেরকে শেয়ার করেন পরে আর কি।
অবশ্যই স্যার। সে বাচ্চাদেরটা না স্যার, এটা রস ক্লাসিফিকেশন বাচ্চাদেরটার জন্য আমি অবশ্যই আপনার সাথে শেয়ার করে দিব স্যার।
Thank you. Excellent presentation.
Thank you very much. Next presentation from Dr. Amitabh Chattopadhyay, and his topic is challenges in treating pediatric cardiac patients. Before that, I want to tell something about Dr. Amitabh Chattopadhyay. He is born in 1969. Now he is resident in Kolkata. He has obtained his MBBS degree from Kolkata National Medical College and a diploma in cardiac in child health DCS from Vivekananda Institute of Medical Science, Kolkata, and diploma in National Board DNB in pediatric cardiology, Kochi Kamakoti Children's Trust Hospital, Chennai. And his fellowship program completed in Rabindranath Tagore International Institute of Cardiac Science, Kolkata, and fellowship also done from Sydney Children's Hospital and Children's Hospital, Westmead, Sydney, Australia. And he has a good number of publications. He is a live member of Indian Academy of Pediatrics and Cardiological Society of India and Pediatric Society of India. Dr. Amitabh Chattopadhyay, please. Thank you very much.
Thank you very much, sir, for your kind introduction. So, and thank you for the opportunity to talk in front of this august audience. So today I'll be sharing a talk. I've just named it as difficulties in interventions in South Asian countries. Now, I'll try to share some of the words in English and some of the words in Bengali, because I think some of the words will be more stressed and given more importance if those are phrased in Bengali. So please pardon if I'm wrong in any point of time. So I'll name the difficulties. I've phrased something like, I'd like to go in this order. Why does the difficulties occur rather? So difficulties, first one is a difficulty in the planning. For example, the first one, as we all have experienced, sign the consent and the proper communication about the procedure. কোন একটা প্রসিডিউর করার আগে আমরা যদি মা বা বাবা বা রিলেটিভ থাকে তাদের সাথে যদি প্রপার কমিউনিকেশন করে একটা কনসেন্ট সাইন করায়, তাহলে মানে আমাদের অনেকগুলো পরিশ্রম পরেকার বেঁচে যাবে, স্পেশালি the miscommunications which might happen later on, and obviously if the parents always, they might create some problems, especially in very difficult subjects, very difficult interventions, so on and so forth. So what is the need, and we have to explain what is the need for doing so. For example, if there is a BPV, a very simple BPV can get wrong at any point of time. So we have to explain to the parents that what is the need for doing so, how sick is the baby, and how sick the condition can deteriorate to. For example, to right ventricular failure, maybe not today, but maybe tomorrow or day after tomorrow. So we have to explain that one. And also the risks involved, like risks involved in vascular trauma, cardiac trauma, arrhythmias, complete heart block, and obviously much more than that. And death can happen even in the simplest of the procedures for untoward reasons. So arrange for the parents and the relatives to arrive in time. Sometimes what happens, suppose we give them the time that they should, the call time is 9 o'clock. So the parents should be there between 7 to 8 o'clock in the morning. And if required, they can stay back. So that there is a delay in taking the patient in the cath lab. Sorry, which obviously not only disturbs the routine of the whole cath lab, but it might also disturb the homeostasis mechanism of the operator itself. For example, you are prepared for the day and you thought that you will begin your day with a simple cardiac catheterization, and then you have a very difficult procedure. If the parents of the cardiac catheterization person doesn't come in time, then suddenly you face the very difficult patient as the first case. And obviously there is a mental makeup for each and every one which should not be undermined at any point of time. The child should be strict NPM, but at the same time run a proper IV fluid, which we have faced several difficulties regarding this one in our institute, and I guess in all institutes. There must be proper hydration. Check the IV lines and they should be properly working. I should be giving a very small example or two small examples. Suppose when the sisters or the nurses go to shift baby to the cath lab, and they, to their horror, they found that the baby was crying and the mother has fed the baby at 6 o'clock. So we had the call time of say 8 o'clock in the morning. Since the baby has taken some milk, maybe mother's milk, which is considered as a solid food, so the baby cannot be taken at 8 o'clock. So there goes a delay of at least 4 to 6 hours and the whole case is postponed. So this is a very simple thing. We should be on the vigil. The proper IV fluid should be running. For example, case of a titulogio very cyanotic kid, and the child has not been getting proper hydration through IV fluids because the IV fluid was extravasated. So no one has probably checked all throughout the line, all throughout the night, and the moment the child is pricked and the cardiac catheterization is on, just after the cardiac catheterization, the child is bound to have a severe cyanotic spell for which the child can land up in a intubated condition, and we might have to do an emergency procedure. So a simple cardiac catheterization can land us in huge trouble, because if we say there is this emergency surgery, either a BT shunt or an intracardiac repair should be done, the whole surgical team, anesthetic team, and everyone has to be prepared on an emergency basis. The case which could have been handled much more sweetly, much more softly, has to be get into complications. So timely shifting to the cath lab, arrange for the staff and the table, a proper holding area, and someone to observe the child in that place, probably before and after the procedure. Shift with all the gadgets. For example, if you are shifting an intubated patient, we have to shift along with the ventilator, along with the monitor. We have to keep and watch that all the lines and the accesses are properly functioning. There shouldn't be any swelling or non-patency. A very simple cause of a delay or a non-cooperation is, suppose the child is shifted to the cath lab, and to our horror we find that in the cath lab the IV line is not working. So on the table where we are supposed to puncture, say at 8:30 or 9 o'clock, then we have to find out an IV line, because without an IV line, the anesthesia cannot be administered. It might be a very, very simple reason, but believe me, this can lead to a huge delay, and obviously the mental makeup, and obviously this should be a trouble to the parents and the child as such. So these very, very small things should be kept in mind. Now, after the procedure, who will remove the sheath? Designated responsible person. That should be trained in removing the sheath one after the other, and there should not be any hematoma, any loss of pulse, and at the same time, there should not be any bleeding, ongoing bleeding or anything else. So usually the sheaths are removed by the doctors or the staff or even the fellows who are present, but obviously he or she should be a very, very responsible person. And the sheath should be removed as soon as possible, because unless you are contemplating another surgery or another procedure, they should be removed as soon as possible. Arrange for the blood and blood products beforehand. There should not be any hurry for the blood and blood products while the procedure is being considered, is on the go, or even after the procedure. For example, there might be a perforation of any vessels, and at that time we need blood. So what we do usually is we keep 1 unit of blood at least in hand, not for diagnostics, but at least for any intervention, so that, God forbid, if any emergencies happen, at least we have 1 blood on hand, which you can run before further units can be arranged. Keep all the instruments and gadgets handy. For example, the defibrillator. The defibrillator should always be kept handy and ready with the number of joules selected for the weight category of the patient, so that the people should not be running in and out of the cath lab during the procedure, unless it's an emergency. বাংলায় বললে যখন অনেক সময় এমার্জেন্সি হয়, আমরা যদি বলি যে সিস্টার এটা আনুন, তো দেখবেন যে 4-5 জন ডিউটিতে আছে, 5 জনই একসাথে কোথাও চলে গেল, কেউ নেই, আবার হয়তো 4 জন একসাথে আবার ফেরত হলো, এসে বললো স্যার এটা কোথাও পাওয়া যাচ্ছে না। This is a very common thing. It's a very, very common thing to find, and this is known as law. So it's an emergency, so it should not be done during an emergency, and this emergency should be avoided. So plan which type of dye to be used according to the status of the patient. For example, if a child has a urea creatinine high, so we have to use soluble dye which has very less osmolality. Otherwise, the patient might go into renal failure. The hydration of this patient should be optimal. Plan which accesses to be obtained. For example, the right femoral artery, left femoral artery, like the veins, or if we want to take an axillary access from the left or the right side, because, for example, if ductal stenting has to be done and the duct is pointing towards the left, so we have to take a left axillary line on that particular day. Otherwise, we go inside and waste the opportunity, then the patient has to come back again on another day. Proper positioning and interaction between the operators. No role is unimportant. For example, sometimes what we feel is the positions in our cath lab, what we do is I usually stand closest to the event intensifier and the camera. My other operators are standing on my right. So my role for the day is to handle the catheters. If suppose there is a device closure, so the other person does the device, or there may be vice versa. But we won't change our positions during the surgery or the intervention. What happens, for example, we have crossed a very, very difficult VSD with utmost interaction between the operators. Now, if we change the operating positions, then the wire might come out as such during the pull and push, and we have to redo the whole thing again. This is just like playing football. Suppose Ronaldo is playing in a forward position. He will never come back the whole field to the goalkeeper position, because he knows if he comes back, then he won't be able to take up the passes which have been given to him, and he may not be able to score a goal. So at that point, the positions are very much described. No role is unimportant. No one is an assistant, or everyone is an operator. So difficulties in hardware. Check the hardware to be used, whether they are present in the cath lab beforehand, because what happens is sometimes if you want a hardware that might or might not be present in the cath lab, then the people have to run around here and there, and that particular kind of hardware, for example, a catheter or wire, might be life-saving for some patient. So we have to plan it previously, and we have to see that everything is present beforehand. If not, either bring it beforehand or use alternatives or improvise. For example, God forbid, you have embolized the device, and that particular snare, for example, 10mm snare is not present. And previously, when snares were not invented, at that time they used to snare the things with the help of a coronary wire, which used to be doubled up and buckled. So be ready for all eventualities. Emergency medication should be prepared, or for any secondary procedures. Surgical backup should be always ready, and take our surgical friends along. They should be informed that such a procedure is taking place in the cath lab, and there should be proper anesthetic and intensive care backup. Difficulties in willpower. I would say that our population is our weakness, and we have a huge load and unequal distribution. For example, most of the centers are situated in the bigger cities, and smaller cities or villages, they do not have access to the cath lab or anywhere else. In our country, presently, we are undergoing a program where there will be DEIC, that is District Early Intervention Center, in all the districts, whereby the people can report even for coronary angiograms or the basic echocardiogram. I'm not sure how long it will take, but one day it might see the light of the day. And at the same time, remember that our population is our strength. kind of the numbers and the varieties we have, the Europeans do not have these numbers and varieties. So we should not be enjoying them, and at the same time, we should be learning from them. Difficulties on the table. There should be a team development and the feeling that everyone is important and everyone's opinion is important. And obviously, recycling the hardware and implants, always be judicious. We do not recycle as much as possible. Like for example, a hardware or a catheter cannot be recycled 10 times. It becomes very brittle and can break inside the body after say 2 or 3 uses. So we have to have a dictum and have a formulation whereby the number of uses may be restricted. So difficulties off the table, post-procedure management. For example, a person, we have done a tetralogy fellow cardiac acceleration. So we have to monitor the consciousness, vomiting, and the temperature. I'll come to the temperature part later on. Vomiting and consciousness. So that we have to see that the patient has come out of the anesthesia, whether there is any consciousness disturbance, whether there has been intracranial bleed or hematoma, which will give us a rough estimation. To monitor the groins, pulses, and the bleeding, because there might be some bleeding, ongoing bleeding, and if the patient is unattended, there might be huge bleeding from there and loss of hemoglobin. Pulses, if there is a thromboembolism, the pile might lose the pulse or even might lose the limb. So the groins should be monitored. We should be monitoring for any dye reactions or allergic reactions. Monitor for the urine output as well, because there might be acute renal failure. So check the hemoglobin, urea, creatinine, sodium, potassium, calcium, magnesium. Write out what about the temperature. We once had a patient who just underwent a diagnostic cardiac acceleration for a Glenn shunt. So we did the procedure for only about 15 to 20 minutes procedure. The child went to the recovery. After that, sister informed me that the patient is having a temperature of 101. So we thought that probably there's due to the dye reaction, and one of our fellows was attending. Then suddenly I received the news that the temperature is about 105, and next moment we received the news that the patient has died. So possibly what happened is these people have severe coagulation abnormalities, and we had given heparin on that day, just like any other cardiac acceleration. The patient had a pontine bleed with hyperpyrexia and obviously had a conal thing and died. So difficulties on the long run. Follow-up is absolutely important for all patients. We should be guarded for the long-term complications. So even if we do a device or a cardiac acceleration, we should always keep a log of what we have done. Even in our country, in some of the cases, we do not have a proper registry. At present, in our hospital, we are trying to build up a huge registry, including the data which we have, which is retrievable and which have crossed, and the follow-up data. For example, unless we have a log of how many devices, or for example, a perimeterous VSD device, unless we are doing plenty of devices, we are doing plenty of cardiac accelerations and plenty of interventions. But unless we have a follow-up data, we cannot publish papers. The Europeans and the Americans are ahead of us because they have follow-up data, which they are meticulously maintaining. And I believe that both in India and Bangladesh, we have a huge horde of people and huge horde of patients, and we should be maintaining their data so that once today we are following the Europeans, we are following their protocols, the protocols which they are making. Probably someday, maybe not today, but maybe 5 years or 10 years down the line, the Europeans will be following our protocol, because our part of the world is totally different. Our demands and our need of the hour, and obviously our patients' makeup is slightly different. So this is the challenge, and don't abandon. I'll have a 2-minute very short video just to make the situation slightly lighter. We should not abandon any procedure at any point of time. So we should not abandon any procedures at any point of time, just to make a fun of it. So I'll show you some of the horror stories now, just to reiterate on the fact that these can be complications and how do we handle the complications. So this was a gentleman, 65-year-old gentleman with a perforation, he underwent a hip prosthesis about 1 month back. And 1 month later, he presented with a huge hip swelling. And when we went from the contractile side, we found that there was a breach in one of the arteries, inside arteries, internal iliac branches, and he was bleeding from that one. So what we did was we initially put a covered stent. You can see there is a wire. We have wired it perfectly. We put a covered stent and the whole bleeding is stopped. But if you see very, very carefully, we made a mistake because the adult cardiologists here, they will easily understand that what mistake we made. See, the coronary wire is actually trapped. The coronary wire is actually trapped inside this one. So when we when we were trying to take off the catheter, take off the wire, the stent was yanked and the stent has come out. So now we have the same lesion as we had begun with, and obviously the stent has come out. So we have a dual responsibility now. Now we have to park the stent somewhere, first of all, catch the stent and park it somewhere, and then again redo the whole thing. So what we did was, it was a hell lot of a difficult task to re-balloon it, a running stent. We inflated a balloon, balloon catheter inside it, and then we parked it somewhere else away from the traffic, and then again we crossed the lesion and we put a coil embolization and we coiled it so that there is no leak thereafter. So this was a lesson that even if we should not rejoice before the final things are done, and obviously there should be an estimation that approximately how much can we do. So this is a contemplated ductal stenting. So all is well until now. We have done a right axillary access, we have done the angiogram as you can see, and we are doing the wiring now. But then we felt that something was not fitting in and the wire movement was not okay. Immediately when we did an angiogram, we found that there is a gross dissection in this patient. So hence we had to stop for the time being. So dissection, wait and wiring. So we waited for some time. The bleeding was controlled. Thereafter we rewired, and again we went through went through this one. But gradually we found that this was not being working. So we went through another way, and thereafter we went from the femoral access and did the ductal stenting on that particular day. So this is an example of fix your target. So as you see, there's a very small VSD, perimeterous VSD, and we were in a hurry for that day. And we only thought that this will be a 5-minute job. We can cross it immediately and we can fix the coronary, fix the VSD. But as you see, there's a very important note here. I'll just show you the place. There's a very important note here. As you can see, the pathway of the VSD and the coronary arteries are the same, and the right coronary artery is the same. If you see very, very carefully, the VSD profile and the right coronary artery are almost the same. So what happened was, we actually went inside the right coronary artery without realizing that we have not crossed the VSD. And in the next moment, what happened is we had closed the right coronary artery just to see that the patient was dying on the table. But to our luck, we could snare out the right device, ADO2 device, from the right coronary artery within a nick of time. As you see, the right coronary artery is totally blocked. People don't believe that we have done such procedures. And we could snare out the device in a very short time. And obviously, we closed the VSD another day. This was, in this particular case, Dr. Jahid was with me. I always show this case, how serious it was and how we managed the case. This was a femoral artery puncture and it had actually dissected out. So we went, the adult cardiologists from the BSMU came to our rescue as well. So we went from the other side and we ballooned the bleeding for some time. And again, we went inside and put a stent. We rewired and put a stent here so that the bleeding is stopped. As you can see, the stent is inflated. So this was one of the ways bleeding which has been stopped by a balloon, and thereafter the stent has been put. Now, in this case, the stent has been put. So this is the way that particular patient was managed. In this particular case, Dr. KK was with me and we were doing a coarctation stenting. So this is a very simple procedure. As you can see, the stent is mounted on the balloon and obviously we start inflating the balloon. But as you see, there's a very peculiar phenomena which is happening. The balloon is being milked out. It is not as a milking out phenomena. So the balloon, which we started from here, you can see the mark. But as the balloon is being inflated, you see what's happening. The dye cannot go inside because of this constriction here. And obviously, as we were inflating, the balloon just milked away, leaving the stent in this position. So at the end of the day, we had a stent which is hanging in this position, partly inflated. And thereafter, it was, as you can see, our catheter, our sheath was here, but it was held. Luckily, we had a wire coverage and wire access, but it was a hell lot of a difficult task to repass a balloon from this constriction. And there was an Atlas balloon which actually saved the day. And ultimately, when the Atlas balloon was put in position, here the Atlas balloon is being inflated, and obviously it saved the day. And afterwards, the patient had a good day. So a very, very simple procedure made very, very complex because of a thing. The reason for this one, can anyone tell me the reason for this one? The reason for this one is a very, very simple reason. The reason why the balloon was milked away. To our hurry, there should be a 4:1 mixture of the dye, because the dye becomes very, very viscous and it was not allowing the full balloon to be filled up. So since there was constriction here, the dye was not allowed to the later half of the balloon, and it only inflated the balloon and had milked away the balloon out of the whole stent. So this was the tale of horror. This is an RVOT stenting. As you see, the RVOT is extremely narrow, and we had done the angiograms. Now we were ready for the wiring and everything. So after that, when we have done the wiring and everything, we were ready just to find out that we have caused some pericardial effusion. See, there is some dye around the whole heart. We have seen it from the lateral and the AB views, and we have seen there was a dye around the heart. So we waited for some time until the effusion was not increasing any further, but our wiring was done. And thereafter, we went through the second time, and we tried doing the case. As you can see, we have crossed the RVOT, and now we are putting a stent. But to our horror, the stent was misplaced, and this stent also came out, and it was lying outside this thing. So here we are trying to sneer out the stent from the wired catheter, and the next view, the stent was very, very difficult to wire it out. So the stent has been sneered, and it has been taken into the groin sheath, and from here the stent is being, we have recrossed it again, and now we have put a RVOT. This is the RVOT stent in position. As you can see, the heart has stopped because the heart could not take this much. And as you can feel, as the stent is inflated, this is not someone beating the tabla, but this is someone compressing the chest, and this is RVOT, and the heart has completely stopped. But luckily for us, the heart could be restarted, and the child came back, and the RVOT stenting was accomplished. So this is a live ASD device embolization. While we were doing the echocardiogram to check whether the ASD is in place, the device embolized, and this is a very rare photograph which was taken by my colleague. And at the same time, this is another live dislodgement. We were lucky, or rather unlucky, to see it. This is the way it dislodges actually, and it picked off. So this device was actually retrieved, and we went in for this thing. This is a live PDA device embolization. While I was looking at the echocardiogram, the device suddenly went along the river. You wait for the last, and the device runs away. So these devices can be, and this was my mistake only. We couldn't judge if the ADO2 device was actually tangling on one of the cordies. So when I released it, it was pulled away from the LV position, and you can see it rotating, but it never went into the PA. If it had gone into the PA, we would have snared it back, but it was actually tangled within the tracheal cordy, and we had to send the patient to surgery. This is an ADO1 retrieval, ADO1 device which has dislodged into the right pulmonary artery. So we went with the Swan Guns catheter, took help of the balloon catheter to reposition the device so that we can snare it and bring it back in through the PDA device delivery system. So in the next one, this is an ADO2 retrieval. ADO2 is relatively easier to retrieve, but there is no easy retrieval in that sense. This was caught near the in the middle of the device, and obviously the first clue so that the device can retrieve is, as soon as you embolize any device, always change the groin sheath to the maximal allowable groin sheath, because when the device is coming back, it is not in the normal shape, and it will take all sorts of a shape which is slightly bigger. So this is a bigger target achieved, but don't forget the other aspects. This is a Takashio's disease which I was doing in a peripheral center, and this was a stent which I had put. And after the stent has been put, it was dilated and everything has been done. But unfortunately, I lost the pulse on that particular moment. When I was coming out and I did an angiogram, I could see that the right-sided femoral artery was almost teared off, almost torn. And there was number of people who were standing beside me inside the cath lab were gradually decreasing. Because whenever this is the dictum, that whenever you are in danger, you will find that the number of people standing beside you will gradually decrease in an exponential way. So by another, say, 10 minutes, you will be standing alone in the cath lab with just a technician, and both of them will be looking at each other. So by God's grace, I started giving some heparin and streptokinase from the other side, and after, say, about 20 minutes, it was recanalized. But the reason why it was occurring, as you can see here, there was some dissection with the dissection flaps. So luckily it recanalized, and the patient was saved at the end of the day. So this is the thing which happens: uncontrolled bleeding leading to an hematoma, because these cyanotic patients, usually they are low in platelets with qualitative difficulties in platelets. This is a pseudoaneurysm of the groin, which can happen when we do both the punctures in the same go. And obviously this is a retroperitoneal hematoma, which is a much larger one, and it can cause to the patient's death. So uncontrolled bleeding and hematoma, always be prepared, anticipate, keep the emergency system and plan B ready, involve colleagues, 2 brains work better, keep the surgical team informed, and keep blood ready. So this was one of our children. After a diaphragm stenting, we lost the pulse and almost the whole limb was to be amputated. But luckily for us, we gave alteplase, that is tissue plasminogen activator, and the limb was resurrected. But obviously he had some muscle issues. This is the amount of subcutaneous tissue which went off after about a month, but the child was saved. On that particular night, we had called the vascular surgeons. They did a fasciotomy and saved the day, so that at least the limb is saved. This is the fasciotomy they are doing, and they were doing a muscle testing basically just to see whether the muscle is still alive. But obviously the muscle was not alive, and at least the muscle was not alive to them. Non-viable muscles. And obviously what we need at the most at this time is the power of prayer of all the religions. We start praying to whatever religions we believe, and this is the to-do list after a complication. So what are the complications to do? The first we do is curse yourself. Why did I take up the case? I shouldn't have listened to my juniors, even though you had selected the case yourself. So this is the usual reaction which you have. Now, curse your colleagues, curse the nursing staff and cath lab technicians. Pray, pray, and pray, and keep up your courage. And obviously, persuade the surgeon, even if you have a recent fight. So, regular dinner contracts might work. So, make sure the surgical anesthesia teams have been informed of the adventure beforehand. You can always tell them that you are going to make history, and the names will also be included if the history is really made. If you are going to do a very, very tough case, time your intervention, preferably in the daytime, not during the evening time. Make sure blood has been arranged, proper hardware and equipments are there, and make sure that the proper consent has been signed. A good interventionist should know when to stop. So we should know when to stop, especially after the complication. Sometimes we have all kinds of reflexes and we go on until we die, but at the same time, we should know when to stop and hand over the patient. So what happens the day after the disaster? The choices in order are: change the hospital, leave your job and retire, look for alternate professions, flee the country, all of the above or none of the above. Anyway, we can choose as always, but exercise our brains together. But never run away from your commitments. And obviously, these are the 3 videos which I always show. This is, on this day, this is known as confidence. Rene Higuita saving the ball by kicking. This was almost 25 years ago now. This video was made about 4 years back. This is Rene Higuita. We all know. And this is known as overconfidence. We should not be overconfident. We should never be overconfident. But you see, what happens is we should never rejoice and leave the cath lab before everything is done and the patient is shifted. So the ball is still valid, and in actuality, it's a goal. So while the other party is rejoicing, in actuality, it's a goal. So, and this one I always star as super confidence. We should never be super confident because we might be bowled out at any point of time. So never take into so much of confidence. We should take our surgical friends always into confidence, and always a team effort with each and everyone participating. Thank you very much. Never be afraid, however strong the opponent might be. So however strong the case might be, so we should never be afraid and keep up the case. Thank you very much, sir, for your patient hearing.
Thank you very much. It's a very good presentation, very difficult cases you have seen. But I think we'll discuss later on. Next presentation will be given by Dr. Naharuma Chaudhary, and she will present the assessing suitability of device closure. Dr. Naharuma.
Sir, am I audible?
Yeah.
Yes.
Assalamu alaikum, the respected moderator, panelists, senior teachers, colleagues. I think the horrifying, excellent presentation after the Amitabh sir has given, my talk will give a clue that how we can avoid this. So today my talk is on assessment for suitability of transcatheter closure. And if we see the history of transcatheter closure, then we have see that in 1975, in 8th April, by Kings and Mills has done a transcatheter closure over a 17-year female who denied to go for surgery for ASD closure. She never confident with the surgery and also don't want the cosmetic purpose surgical scar mark over her chest. So King and Mills, they used double umbrella device, which is non-retrievable and non-centric capability. So they have put successfully on that case, only they have took sizing balloon, and that was 2.5 mm ASD, and they put a 35 mm device with a 23 size sheaths. It is huge. And if we see, this is non-retrievable. If the position of the device is not suitable, they cannot take or retrieve it. And so they have to send the patient to the surgery. For these things, there are a lot of modification came to the device. And at least in 1997, Dr. Kurt Amplas has invented an innovative device that is double disc self-centering waist, and it is soft, and we can put in different sizes of septal occluder in different age and different weight group of patient. So what is the history of transcatheter closure in our hospital? We have done till date 1,193, and we have started in 2014, and ASD is the most, that is 716, and then PDA 403, and the VSD 74. So why pre-procedural assessment is needed? From the previous lecture, we can assume some things, that if we are taking without a casual assessment and take the patient to the cath lab, and after the graphy we tell, no, we can't do with this procedure. It is a mental trauma for the patient and the family member as well. And also, if we linger the procedure for a long time, there can be any complication that can endanger the life of the patient. So we have to be precise over the pre-procedural assessment. So we have to know when to close, when not to close, and what is the indication, and when to close and what will be the timing, and how to close. Should we can go for device closure or surgery? And what should be the ideal device for this patient? So why transcatheter closure is preferred over surgery? In different data of international, it shows that similar success rate and mortality is almost same in both groups, but the morbidity was lowered in transcatheter close, and the hospital stay is also shorter. The things that I kept in my bottom, that scar marks, but sometimes it is the #1 indication that patient don't allow the scar mark over his body or chest. So initially I start with atrial septal defect. Let's check what ESC guideline that is published in 2020 August, what they said about the ASD. If there is RV volume overload, regardless of symptom, no PA pressure is normal, or PVR is less than 3 Wood unit, rather patient having no LV disease, this is class 1 indication. And the method of choice is device closure, it is class 1 indication. And how to assess? Transthoracic or transesophageal echo is the gold standard. We can evaluate the size of the ASD, exploration of the residual septum's morphology, rim size and adequacy, and the quality, and have to exclude the other additional defect that need for surgical closure. And also have to check the pulmonary venous connection is normal or not. In that, 3D echocardiography give a better delineation of the ASD morphology. So what are the contraindications that we should not touch initially? According to Indian guideline that has came in January 2020, it was told that the deficient rim, if it is less than 5 millimeter, we can spare the aortic rim here. And if weight is less than 15 kg, and defect size is more than 20 millimeter per meter square, we should not try initially. And cardiac cath also give a better support of the echocardiography. Those echocardiography, if not give a good clue about the pulmonary vein, then we can do cardiac cath. And in post-residual cases, we know there is fibrosis. So sometimes the window is not good. So here also with balloon sizing, we can give the anatomical assessment. And the cases that is borderline PA pressure is high, or that there is increased PA pressure, we can do the shunt calculation, and suitability is present or not can check. And the LV disease with increased filling pressure, what is that? If we find a case with a good rim, that is can be suitable for the device closure, but we have to be careful for the adult case, especially if their patient have hypertensive changes, LV failure, then we have to first initially do the balloon sizing and occlude the ASD and see the LV EDP is rising or not. Sometimes if increase, the ASD will save the patient, but if closing this ASD, it will hamper the life of the patient. So these are the two views, transthoracic and transesophageal. I am keeping side by side so that we can assess. In 4-chamber view, we can give the mitral ring and the posterior superior ring. Here it is adequate with good quality. But if we see, we can bring this 0 degree, and this is a mitral ring. This is thin and floppy, and the posterior ring is also flimsy. And in short exit, if we see in great vessel level, there is short aortic ring, and the anterior, posterior inferior ring is adequate, and we can get this transesophageal 40 to 60. There is no aortic ring, and the posterior ring is adequate. And this is the bicaval view in transthoracic view. This is the SVC ring, and this is the IVC ring, which is adequate. And we can take it 90 to 110 degree, and this is the IVC ring, and this is the SVC ring. So we take in three plane, and we assess the all rim and take the highest diameter. We give the 2 axis, short axis or long axis, and take the size. Highest diameter we take, and the device side will be 2 millimeter larger than the highest size of the measured. And we can take 4 millimeter if the ring is floppy. So we have to check, is there normal pulmonary vein connection is present or not in 4-chamber or CREV view. And sometimes 3D echo gives a better delineation. Here we find that RARV is dilated with 2 small ASD, separating the intervening tissue is more than 7 mm. So in this transesophageal echo, we are deciding that we should take a 2 ASD device. But when we have done this 3D echo, then we find that there is a circumferential ASD with a central stop. But if we see the ring, it is good and well enough. So we take a large device, and with a single device, we just occluded this septum. So what is the recommendation with PFO, patent foramen ovale? If there is paradoxical embolism and excluding the other causes, ASD closure should be considered regardless of the size, providing there is absence of pulmonary pressure and LV disease. And this is 2A indication. And what about the LV disease? Just I explained. It is recommended to perform a balloon testing and carefully weigh the benefit of eliminating left to right shunt against the potential negative impact of ASD closure on outcome due to an increase in filling pressure. Should consider closure, should fenestrator closure can be done, or no closure. So this is class 1 indication according to ESC. So we have done a case, post-surgical cases, where sometimes the echo window is poor. So we take the balloon and have done the sizing, and there is waste, and measure the size, and we put the device and close through atrial septal defect. Now, ventricular septal defect. So what that ESC guideline tells here is also, if there is chamber dilatation present in left side, if there is no PA pressure or normal PVR, we should recommend regardless of symptom VSD closure. This is class 1 indication. And if there is no volume overload, no significant left to right shunt, but there is repeated episode of infective endocarditis, this is class 2A indication. And what our guidelines say? If there is QPQS is more than 1.5, PSP is less than 50% of systemic pressure, and pulmonary vascular resistance is less than 1/3 of systemic, then surgical or device closure, if suitable, it is class 1 indication. So AHA and ESC recommended that this type of device should be closed by transcatheter closure. If there is surgical residual VSD, if surgeon cannot close or poorly accessible, or muscular device, muscular VSD that is centrally located, and the perimembranous VSD. There are some special scenarios which can be done but not to be followed by the beginner. So this eligibility criteria that I have taken from the Indian guideline that has came in 2020 January. Weight have to be more than 8 kg and 5 kg if there is muscular VSD device, and perimembranous VSD device we can close if there is ring of aortic margin that is more than 4 millimeter from the aortic valve. So what should we not touch? if there is irreversible pulmonary vascular disease, if there is pre-existing LVP or any form of AR or associated lesion that requires surgery, or inlet or subpulmonary VSD should not be touched. So device should not be deployed if any of the following findings developed at the time of procedure, that any degree of AR, conduction defect like complete heart block, LBP, mitral or tricuspid regurgitation. So we have to be cautious. So what type of device we can choose for a membranous VSD? Asymmetrical membranous VSD, where this should be in the aortic region. There is only 0.5 mm retention disc and the LV disc is 5 mm. So in case of a membranous device, this can be chosen. Or sometimes symmetrical membranous device we can use, and sometimes muscular VSD device. It's variation form of duct occluder, AD1, AD2, additional size, or vascular plug we can use, along with LifeTech multifunctional occluder can also be used. So which perimembranous VSD should be closed? We are happy when we see this aneurysmal tissue. So when this is less than small 6 millimeter, we took ADO2. ADO2 is a size from 3 to 6. So when there is less than 6, we can try with this soft ADO2 device. If there is multiple exit, we can take 2 ADO2. If it is more than 6 millimeter, we can try with ADO1. This ADO1 is size from 5 to 16 size. So according to size, we can choose this ADO1. If there is more than 6 millimeter with single exit, we can take any of the symmetrical device, muscular device can be used. If there is no aneurysm, I have shown that we can use this asymmetrical device. So how to assess? Here also, echo plays a gold standard role. So we have to initially type of the VSDs have to see, then see the presence of aneurysm and how much exit point is present on RV side, and it is more than 4 millimeter away from the aortic valve or not, and exclusion of the other additional defect. And 3D echo give the better delineation of the VSD morphology, and cardiac cath can supplement where there is other associated lesion is present or not, or sometimes post-surgical residual cases where the window is not good, and for the physiological assessment in shunt calculation. So there are few scenarios that first, this is a small children, 2 year, 8 month female. We are following this group because she is asymptomatic. She has restricted VSD, which unfortunately she developed infective endocarditis. So we managed medically, and this is the VSD that is restricted by septal leaflet, and this is the vegetation. So when we medically managed the patient, when there is vegetation resolved after the 2 months, we have done the LV and we decided to close this VSD, and we have done with the ADO2 device. And if we see, this is well positioned and away from the aortic valve. My second case is 1 year, 10 month male. She has undergone tetralogy of Fallot surgery, and it was 1 year she developed gradually symptom. And if we see, there is a left to right shunt, and there is residual VSD at the lower end of the VSD patch, and it is 4 millimeter. And we have done a graphy, and we take decision because patient is symptomatic. So this is the VSD, and we closed with ADO1 device with 10/8 size. And this is another post-residual case. And if we see, there is not well delineation of the VSD. We cannot confirm the size of the VSD. So we have done a balloon sizing, and we find this is the wedge. So this is also suitable. And here the cardiac cath and balloon size can help us to take decision. This is another 46-year male who is hypertensive smoker and history of old inferior MI and recently developed anterior MI that we have done in 2017, and this is the first survival case. And this is the VSR that we found in apically placed, and we have done the graphy, and we can see this is the VSR flow left to right shunt, and we take post MI VSD device 10 mm size, and we deploy it. And after this is post procedure, the device in situ, and patient is still now on follow-up. And this is a clean cut case, basal muscular VSD, and this is the VSD, and with left to right shunt, we can appreciate this. And we have done LV graphy here, and this is also suitable and away from the aortic valve. And we put a muscular device 10 mm, and this patient is also behaving well. So this is a perimembranous VSD with multiple exit, 2 exit on the RV side, and there is 2 ADO2 is put on these cases. And sometimes there are very difficult cases that Swiss cheese type of VSD where the both surgeon is also very tough to reach here. There also we can put a device here, larger device here. And next to patent ductus arteriosus, if we see the recommendation is same like VSD, LV volume overload, regardless of symptom and no PA pressure and PVR if less than 3, it is class 1 indication for closure of the VSD. And the choice of recommendation is device. And what are the eligibility criteria? This is also by the Indian guideline. If the baby's weight is more than 6 kg, we can do device closure, coil occlusion, or surgical ligation. This is class 1 indication. If it is less than 6 kg, then surgery ligation is the class 1 indication, but we can try device or coils. This is class 2B indication. And what for the preterm baby? We can do feasibility of device or coil closure of PDA has been demonstrated, but high risk of adverse event is high, and this is class 2B indication. So which cases should be surgically recommended? If there is progressively enlarging PDA, if there is aneurysm, endarteritis, or PDA with unusual shape. So there also play the echocardiography a great role. If we have to delineate the morphology of the duct, we see the pulmonary pressure and the associated lesion. So if we see this is a normal human arch of aortic arch, and this is the duct, and this is the PA, and this, if we correlate with our echo, this is the ductal view that we take in the first intercostal space where the pointer will be at the 12 o'clock position. This is the PA, and this is the descending thoracic aorta. So this is the pulmonary end, this is the aortic end, and this is the length of the ampulla. So here we can identify the shape of the PDA and the length of the and the diameter of the PDA, so that we can assess which type of device should be put. If the length is longer, then we have to take a longer shank device. If the length is small of the ampulla, we have to take a small shank device. So there are different variety. There is short ampulla, and there is long ampulla, and there is cylindrical shape in different variety of PDA is present. So what are the different PDA? We can use the coil if there is ampulla and if it is less than 3 millimeter. ADO can be used in a small, ADO1 can available in size of the 5 to 16 in any size of this we can use. And ADO2 is soft device we can use in case if it is 3 to 6 millimeter. And ADO2 additional size and piccolo we can use if this is less than 4 millimeter. We can give a trial on the preterm baby, and vascular plug when the length is longer we can use this device. So this is a short duct with short ampulla, and this is a PDA of short ampulla with a large PDA. So there is choice of device is ADO1 or any short shank, as because ampulla is short, or we can use the muscular VSD here. And this is a large ampulla but a small duct. There is a large ampulla but the small duct. We can use, if it is less than 3 millimeter, we can use coil. And if we see here, it is a large ampulla with a large duct. So the preferred is muscular device, ADO2 or vascular plug. So this is an example where we have we see the device, good ampulla with a short PDA, and we put a ADO2 device, and we identify is the position is stable or not, and the original shape is well delineated here or not, and we check the aorta and the LPA is obstructed or not. And this is another scenario where there is a large PDA with a large duct, and we take a ADO1 and that large device, a large PDA we occluded with the ADO1 device, and when we are confirmed it is occluding the device no residual or not obstructing the aorta or PA, then we deploy the device and release that. And if the hemodynamically it is small, then we can use coil or device. If large, coil will just embolize. We have to use the device. If there is subsystemic PA pressure, any design of device can be used. But if there is PA pressure is systemic, it is better to use double disc design or reverse shunt. Otherwise, it will embolize. So why assessment is so important? Because if we are not sure, it can embolize. There can be cardiac perfusion for the malrotation or malposition of the device, or catheter manipulation, can develop stroke, can happen death, or residual shunt with hemolysis can happen, can develop complete heart block, or any form of regurgitation in aortic, mitral, or tricuspid valve, or it can stenosis in LPA or isthmus. So take-home message is the transcatheter closure is safe, effective, and less invasive than surgery, and more efficient than medical treatment. And technically it is simple, but decision-making is crucial and can easily be life-threatening if not appropriate. And pre-procedure evaluation is the mainstay of success. And comprehensive imaging is the heart of successful outcome of transcatheter closure. And thank you all for listening and being with me.
Thank you, Dr. Nahanuma, for your presentation. It's a very beautiful presentation. Next one is presented by Dr. Tawfiq Shahriar Haq, Associate Professor. And he will present some case presentation, especially some CDs. I hope Dr. Tawfiq Shahriar will present the cases. Okay. Thank you.
Assalamu alaikum. Thank you, Honorable Chairperson, the respected panelists. First of all, I would like to take the opportunity to thank National Heart Foundation, Hospital and Research Institute Authority, and Department of Cardiology for allowing a team that performs pediatric and adult congenital heart disease intervention to grow in a cath lab, which is doing more than 5,000 interventions, cardiac interventions, adult cardiac interventions per year. Without their active support, we couldn't have survived. I would also like to thank our head of the department, Professor Fazila Malik, and senior consultants, Bodiu Zaman sir and Nazir sir, for actively encouraging their patients to have intervention, congenital intervention with us in the initial days, which increase the confidence of both the parties. And with time, we have managed to perform more than 1,000 interventions. As Naharuma has shown, our number now stands at 1,193. Of them, we have almost 70% female patients. And among our cases, 60% are ASDs, 6% are VSDs, and 34% are PDA patients. So the aim of today's presentation is not to demonstrate how a procedure is done, but rather to show to our young cardiologists or other practitioners who have joined us that what things are possible to do in pediatric cardiology. So let me start with balloon pulmonary valvuloplasty. Pulmonary stenosis at young age is not only life-threatening. If they come through it at adult age, adult patients, this is really lifestyle limiting. So in this patient, you can see it's a 6-month-old patient, very tight pulmonary stenosis, very poor RV function. And in this situation, at the first stage, you can see we could only manage to take a coronary wire through the pulmonary opening, and we gradually dilated it. And our first balloon was a coronary balloon. Then we took a renal balloon, 7 millimeter, and finally we took a valvar balloon to adequately dilate the pulmonary stenosis. And in this case, you can see it's a post-TOF repair pulmonary stenosis after 2 years of surgery. And in this case, you can see we took a valvar balloon, 14 millimeter size, and managed to dilate it. The surgeons were not eager to take the patient up for another surgery. Bicuspid aortic valve with severe aortic stenosis is another problem with the children. Again, life-threatening conditions, severe LV dysfunctions, and as the guideline goes, balloon valvoplasty has good results beyond neonatal age as well. In ideal case, a successful intervention can achieve a good LV function, and the first operation can be delayed until the patient is an adult. However, with increasing age, additional aortic valve insufficiency gains more importance. So it becomes difficult to balloon dilate once the child has crossed a certain age. The intervention should begin with balloon valve ratio 0.8 to 0.9, just which is not like in pulmonary stenosis or PTMC where we take equal size or larger size balloons. During the procedure, particularly in older children, functional cardiac arrest by rapid ventricular stimulation through temporary pacemaker is done, or adenosine may be used to stabilize the heart rate. The guideline says in newborn with isolated critical valvular stenosis, in case of duct-dependent situations, pulmonary aortic valvotomy can be done. And in children with isolated valvular aortic stenosis, when there is depressed LV function, there is peak gradient more than 50, resting gradient more than 40, balloon valvotomy is an ideal choice. And this is one of the cases, a child, you can see very poor LV function. We crossed into the LV with a wire. There is rapid ventricular pacing, and you can see that small wedge that was released, and this small amount of release in stenosis allows the child to have a good LV function, grow older, maybe before the age of 12, 16 or 18, we can do another dilatation, and then he can safely have a valve replaced. Then, as it was said, as patent ductus arteriosus, these are maybe the easiest of the interventions to be done. In our center, we do through a venous puncture only. We cross from the pulmonary into aorta to an graphy to visualize the ductus arteriosus and deploy the device. As you can see here. And once the device has been deployed, we use the same catheter to check the position in two views, in lateral and cranial view. When we are satisfied and we do echocardiography to be sure about the device position, then we can release the device. But always, it is not always so easy. In adult patients, the position of the duct varies, and it is not so easy to cross from the pulmonary artery into the aorta. In those times, we have to come retrograde, form an AV loop, and then cross with the delivery sheath and do a PDA device. This AV loop formation is a unique and very innovative thing from pediatric cardiology that I have learned. You can do devices like to close PDA, ASD. Even I will show a case where we have closed an ruptured of sinus of Valsalva through this maneuver. And VSD closer, we have seen some cases. This is another case when you have a small VSD with aneurysmal tissue, and you can do it with the EDU 2 device. It's very easy. You come retrograde through the LV, cross into the RV, and just deploy a EDU 2 device. Sometimes this is not so easy. When it's a larger sized defect, you have to form an AV loop. Here you come retrograde, take your wire into the superior vena cava or the pulmonary artery, and then you snare it down, form an AV loop, and come from the venous side to deploy a large size device. We use this. This system is used so that we don't have to take a very large sheet in the artery, or we can align the devices with the shape of their discs so that it doesn't embolize with higher LV pressure. You see, we came retrograde, then we formed the AV loop, then we have taken this device to the venous route and have deployed it. After checking the position, we can release the device. This is another case of post-surgical residual VSD. It was a very small 3 millimeter VSD in a very small 18-month-old baby. We did this with an ADO 2 device, 5 by 5 ADO 2 device, and the child didn't have to go through another surgery for this. Atrial septal defects, as you have seen, 60% of our cases are atrial septal defect. This is the normal thing we do. We come through the venous system, cross the ASD, park it in the left upper pulmonary vein, and then take a device and deploy it. Sounds simple, but when you get stuck, it's not actually that simple. And sometimes there are very small rims, the alignment is not correct, and you need to, in those cases, you really need to take support of an equalizer balloon. Here you can see we have supported the device with a balloon and gradually deploying it. And it was successfully deployed. We checked the position and later released it. So this is after we have been doing all these cases, we gained courage and started walking out of our league. This is a case of ruptured sinus of Valsalva I'm going to show next. So these are the normally acquired causes are bacterial endocarditis, degenerative conditions like atherosclerosis, and there are congenital causes when ruptured sinus of Valsalva is associated with VSD or some connective tissue disorders. This patient is a 60-year-old patient who came to us with sudden onset of shortness of breath and palpitation. Echo revealed a ruptured sinus of Valsalva. We did this root aortogram and found that their RCC right coronary sinus ruptured into RVOT. Again, we formed an AV loop. We talked with our surgeon initially, and they encouraged us to go through the procedure and try closing it percutaneously. So we initially checked the pulmonary artery pressure for this patient. Then we formed an AV loop we came from the aorta, took a Terimo wire, parked it in the pulmonary artery, and snared it down to form an AV loop. And then we took ADO 2 device, 8 millimeter, with a 4 millimeter rupture, and you can see we successfully managed to close this defect. Actually, these procedures look easy, but as we did it, it increased our confidence for doing this type of cases. This is another case of occluded superior vena cava or after Warden's procedure. We know Warden procedure is usually done for ASD with partial anomalous pulmonary venous drainage. This was a 2-year-old child who underwent Warden's procedure, and 8 months later, he came back with swelling of the upper part of the body. We found that the junction of the SVC with the right atrial appendage was obstructed. So we talked with the surgeon, and they encouraged us to do the procedure. So you can see we first do an venogram and found that actually from the left side there were multiple outflow channels which was draining into the right atrium through the coronary sinus. We also checked the pulmonary veins to see if there was any pulmonary venous obstruction. Then we took a jugular venous puncture, and you can see the site of obstruction on the right panel. Then we crossed the lesion with the same guide wire that we used to make the puncture, and we took a coronary wire and parked it in the pulmonary artery to have better success. Then we took a coronary balloon, dilated the lesion, and the largest diameter stent we had was a nephro stent. It was 7 by 16 millimeter, and we positioned it and dilated it. And then we post-dilated it up to 8.5. And you can see the obstruction was relieved, and it's almost 18 months, and child is doing very good and he's on a single antiplatelet now, and still now the flow is very good, and we are very happy. And finally, another case. This is a 19-year-old girl who came with an ASD and pulmonary artery pressure of more than 100, but she presented to us with choking sensation on mild exertion, which is very unlikely. We don't get this type of symptom in patients with severe pulmonary artery hypertension. So we planned a cardiac cath, and we found there was severe stenosis of the left main. So we had no choice but to do a stenting for her. So we took a floppy coronary wire, crossed into the LAD. We took a cuspal wire, took a 4x12 drug-eluting stent, and we dilated it, positioned it, and dilated it with very good result. It was an irreversible pulmonary hypertension. She still has some different sort of symptom, but she is now able to do her daily activities on her own without any symptoms of choking or things like that. So I don't want to take more time. I have some take-home messages. The first thing is, parents of a child with congenital heart disease need to be counseled compassionately. Close follow-up, as per advice of a pediatric cardiologist or a surgeon, is very essential. Intervention may be needed as early as just after birth. In the modern era, all defects do not need surgical closure. And finally, we all should work together to set up an effective early screening program for the diagnosis of congenital heart disease. With this, I would like to conclude. Thank you very much, Honorable Chairperson, panelists, and the audience.
Taufik Shahriar Haq, very excellent presentation. Just now, the discussion is open for all. Dear panelists, Professor Muhammad Zahid Hussain, you can comment something about total presentation, especially Amitabh Chattopadhyay, Dr. Taufik Shahriar Haq, Naruma, and Jasmine. শোনা যাচ্ছে না, আপনারটা মিউট করা।
Muted.
আবার মিউট করা। হ্যালো, শোনা যাচ্ছে না।
Okay. Yeah. Respected chairperson of today's webinar, organized by National Heart Foundation Cardiac Course, Professor Nazir Ahmed, Senior Professor of Cardiology, National Heart Foundation Hospital and Research Institute, the learned panelist, Professor Ibim Abdul Salam, ex-head of the Department of Pediatric Cardiology, National Institute of Cardiovascular Diseases, and also Dr. Abdullah Shariar, who is now the head of the Department of Pediatric Cardiology, National Institute of Cardiovascular Diseases. The learned speaker, Dr. Amitabh Chattopadhyay from Narayana Super Specialty Hospital, Howrah, West Bengal, India. Dr. Jasmine Hussain, Assistant Professor, Pediatric Cardiology, National Heart Foundation Research Institute. Dr. Naharuma Bhaidar Choudhury, also Assistant Professor, National Heart Foundation Hospital and Research Institute. And finally, Dr. Shahriar Taufik Haq, Senior Consultant and Associate Professor, National Institute, National Heart Foundation and Research Institute, and learned participant. Assalamu alaikum. Actually, 4 topics Dr. Jasmine has presented on, basically how we can diagnose the congenital heart disease, who do suspect how to diagnose the congenital heart disease. And Dr. Naharuma has presented on assessment of suitability for intervention and also for surgery. One thing Dr. Jasmine Hussain has presented on the basic thing, how to diagnose congenital heart disease. and Dr. Naruma Aifada Choudhury has presented on the suitability, assessment of suitability for intervention. It is also applicable in case of surgery also. Because if we do not assess the patient meticulously, precisely, then will not be successful in intervention. Also, surgical outcome also will not be good, and also the procedure failure and a subsequent complication because of intervention and surgery might occur, and that might cause harm, complication as well as death to the patient. And Dr. Amitabh Chattopadhyay, very, what I should say, delicately has presented about how we should do the procedure in the cath lab, because everything what he has presented should be adhered. Even what he has mentioned, procedural guide wire, the sheath, the puncture needle, everything is important. He has mentioned about the defibrillator. If you don't have the defibrillator, when in need, if you don't have the defibrillator, patient may succumb to death because of this kind of intervention. But one other thing that he has mentioned, that we, while doing the procedure, every preparation, the preparation in the cath lab, and utmost important is every time you should be very much cautious. Every step is important. He has shown on slide that there was a femoral artery puncture. Actually, my colleague was doing the procedure, and they, while doing the procedure, they could not cross the, we could not enter the LP. Suppose there was aortic stenosis, I did not do the echo, but I was present in the cath lab because it was from my department. Subsequently, we take out the catheter and try to reach the, but while doing the procedure, the sheath was a bit out. I don't know. I just failed to pro again. I pushed the sheath, but vascular sheath, but it was not going into the. It wasn't going inside. Someone actually, then I left it, and I was waiting for something else. Probably someone has forcefully pushed the sheath, and that caused puncture of the femoral artery. Subsequently, what the procedure we did with Dr. Amitabh Chattopadhyay he has shown. And what is utmost important, also Dr. Amitabh Chattopadhyay has said, we are lacking in that facilities. The surgical backup is very important. National Heart Foundation Hospital is lucky enough that they have got the pediatric surgical backup. But in Bangabandhu Sheikh Mujib Medical University, we have the backup, but we don't have the pediatric cardiac surgeon. So that is one thing, and I must appreciate and give thanks to Dr. Abdullah, Dr. Tawfiq Shariar for his excellent job. Within the short time, he has done the good number of intervention in National Heart Foundation Institute, and he has shown some rare case of intervention that he has performed in National Heart Foundation Institute. With this, here we can see that we have progressed within short time in Bangladesh. We have progressed significantly in the field of intervention in pediatric cardiology in Bangladesh. I should not undermine anybody, but what I feel that we should also make progress to build up pediatric cardiac surgery simultaneously. As well as we should make progress in pediatric cardiac intensive care. We also lack in pediatric cardiac intensive care. If we can coordinately do the intervention with the surgical backup and with post-procedural, the pediatric intensive care, our outcome will be very good, and our patient life will be safe, and their future will be very good without any complication. With these few words, and again expressing my sincere thanks and gratitude to the organizer for inviting me as a panelist on this important seminar, and particularly special thanks and gratitude to Dr. Amitava Chattopadhyay. He gives so many times BSMMO, National NICPD, as well as Heart Foundation. On behalf of all the pediatric cardiologists of Bangladesh, I express my special thanks to Dr. Amitava Chattopadhyay for giving us so much time. Thank you all. Thank you.
Thank you very much, sir. Next, Professor ABM Abdul Salam, please.
Thank you very much. Am I audible?
Yeah.
Thank you very much, Nazir sir, and my friend Dr. Buddhu Chaman, and Ashok Datta is still, I think, is with us. Thank you very much. Actually, I enjoyed all 4 lectures. So nice and elaborate. It was really, it was although it was exhaustive, but one day you have covered a lot of things. And the history of interventional pediatric cardiology in Bangladesh started very not so far away, around 2000 here, where Nurnar Fatuma started. Then in 2005, I started with PDA device closure. 2007, I first did ASD device closure. And 2009, I did the BSD closure. So these are a very small history, actually. And this was not done by ourselves, in fact. There was a lot of support from different corners of the world, particularly from India. And I started with the work of intervention in pediatric patients with the help of some charity program coming from Dubai, as well as from Saudi Arabia, as well as from Qatar. And they were coming with multinational team, that is from USA and other. So actually, you all are interventionists, you know better than me. This is a learning curve. We all are in a certain stage of learning curve. So for the junior, which I want to emphasize, that is the basic things of cardiology, starting from the anatomy, physiology, pathology, and also the embryology for understanding, better understanding. So as well as if you want to go to be an interventionist, you have to know the basics of intervention. As Dr. Tawfiq Shahriar is doing, it is not the adult cardiologist or pediatric cardiologist, it is the congenital cardiologist. So whatever the background, but pediatric cardiology actually, Professor Zahid Hussain has started only the MD pediatric cardiology, and soon CBS pediatric cardiology is going to be start. But surgery we are lacking, as told by Professor Zahid Hussain, we are very much lacking. Regarding the papers, actually, you have 2 nice speakers in your center. One is Naruma and another is Jasmine. They have a nice, spectacular, beautiful presentation with beautiful slides. I enjoyed this, and with a lot of information. And note, there is a class presentation, all were lucid and logical. The thing is, there is the essential criteria for the suitability assessment of device is very important. Before a decision, it is very important whether it is doable or not, as nicely described by Naruma. But the thing is, Professor Amitabh, what he has shown in the different classical example of different nightmare case, different difficult case with complication. In such meeting, we usually share our success, but sometimes we undermine our failure. But Amitabh, truly speaking, actually, the person who have to be interventionist, he have to be very good nerve. He have to, he should be cool like that. Professor Tawfiq Shahriar, as I told, as I saw since he was a student of NICVD. So he's very cool. So his team should be successful. That is my idea. As you have shown, there are nearly 1,193 cases they have done. And in ICPD, when I left retired, we have done 2,200 some cases, 73 cases. And I think after that, COVID has started, the number of cases decreased. Shahriar would be able to say something. But these are not great number of cases. And we are not doing many difficult cases. And the more you will work, more you will be able to perform the difficult cases. But the thing is, we should have a consensus. And by this kind of conference, we can to build up the consensus among ourselves so that we can be helpful for each other. Not like that when I will face a complication in my cath lab, Shahriar, Ataria, all everybody will let me alone. As Dr. Amitav told this. And this is the scenario. Actually, we people are not, sometimes we do some backbiting and stuff, but it's not a, really it is a hard job, tricky job. Sometimes everybody has some tendencies. I am going to make a history. This is the first case done in Bangladesh, like that. But if I am not in a trouble, during my tenure in NICBD, I have a lot of complications. I have been criticized by the media as well as some people are threatening me like this. A lot of nightmares I passed. So these are the things you have to face. And before doing any intervention, from simple PGA device closure to coronary camera fistula device closure, you should be very precise whether it is doable or not. It is not a one-man show. It is a teamwork, starting from nurses to the anesthetist, intensivist, surgical backup, and everything you should check. You should make a checklist before going to cath lab, as well as before from the pre-operative pre-cath order. You have to see meticulously. So more the case, more the beautiful and organized teamwork you will have the more success. With these few words, I want to conclude for the excellent webinar you have organized, and my learned colleague will say something. We'll learn from it. And again, I want to congratulate and thanks Amitav for his nice video. Actually, we interventionist, he's a legendary interventionist, I should say, among the world. Actually, we are proud of him. He's a son of this soil also. He has a special softness or affection for Bangladeshi people, like Bengali people. So I always bless him for his long, healthy life. Thank you, Amitav, for your excellent demonstration.
Thank you very much, sir. Thank you very much.
Yeah, I really enjoyed your cases. And Tawfiq Shahriar has, in his demonstration, you have not shown your mortality. And I wanted to see your nightmare cases and complication cases. Although it is a basic course, I think we'll see in later on. So we'll learn you, Guy. You young people are coming in this field. We, as a senior, we are very much proud of all of you, like Jasmine and Haruma. I can recall always when they came to NICBD to learn ECO, that those days. Now, I'm very much glad as well as proud that they have exceed our capacity, their teachers' capacity. Thank you very much. Thank you, Nazir sir. Thank you, my friend Dubir and Ashok Dotto and others.
Thank you, sir. Thank you for your brilliant comments. And next, Dr. Abdullah Shahriar. Thank you very much for your presence, sir. And please say something about our session, please.
Okay. Thank you, sir. Am I audible?
Yeah.
Yes, Shahriar.
Yes, I'm audible?
Yeah.
Okay. Thank you, sir. Arranging such a beautiful seminar, and I must thank you, the authorities of National Heart Foundation. It's a pure, I think, the pure academic programs. And in this COVID arena, COVID time, we have lack of, don't have some precise time to go for a detailed cover up about academic works along with our clinical procedures. But this kind of webinar, I think, very much helpful to us. I won't go for details because there's constraint of time. I just give some comments about our very good speakers. They have given us some detailed about the arena of pericardial disease, cardiology. First, about I'll much give thanks to Jasmine. Dr. Jasmine has given us some ideas how to reveal congenital heart disease, both cyanotic and acyanotic heart disease, very meticulously. I think very very precise way, very comprehensive way. These are the things I think the newcomers, those who will come in this arena, I think they will be very meticulous. And these things have given a very nice delivery by Dr. Jasmine. Then I must appreciate about the delivery of Dr. Naruma Ivy. She has also given us the very beautiful cover up about the suitability of procedures of different things revealing congenital heart disease and our device also, and all the hospital's background, where to go, where not to go. These are the things he has given us cover up. And I must also thank to Tawfiq Shariar also. In fact, Dr. Tawfiq Shariar got the advantage. He has come from the adult background, but he has intense thirst of knowledge for our field, our special pericardiology field. That's why within very short time, Tawfiq Shariar has shown his potentials in this field, and so from his background, from his mixed background, he has shown how to go for out of difficult case he can go through, and he's given us. In fact, he's given us that enormous, I think, spirit to us. He's from lecture, and we'll go further from his learnings. And last and not least, our great teacher from Amitabh sir. In fact, he's our friend, philosopher, and guide. I must congratulate and thanks to Amitabh sir. He has given us an audiovisual delivery, nice audiovisual delivery, and he has shown that everything is important. And whenever we must graze in this field, we must be very sincere, having keen eye and academic depth, very methodical and organized. And he has given some nightmare of cases where we can learn more and more things. There is nothing the end of this arena. We have to, more we work, more we graze, more we conquer, more we learn. So that's all. I must thank everybody. Everybody is my teacher. In fact, I'm now in a state. I'm not in a day, not in an hour. I came to the state. I am coming to this learning cover up learning field from my. I think our teachers, like our mentors, like Professor Abdul Salam, Professor Mujahid Hussain sir, Najid sir. He was also very I think is a great academician. He has got also role. Though he's in a different institute, but the breeding is from this NSABD. So they have some. I think they from their output, from their I think hand-to-hand cover up. We learn all these things. This is the way we should. I think we should gain all these things. The newcomers will come in this field of pericardiology. They should know how we'll gradually enrich ourselves through learnings. So thank you very much. I won't go further. Such few words, I'm going to end my delivery. Thank you very much. Thank you, sir.
Thank you very much for your wonderful discussion. Next, Dr. Badiujaman, can say something? Can you say something? Yeah. Dr. Badiujaman?
Yes, thank you. Thank you very much. Nothing much to say actually, because all the speakers and presenters have presented very nicely, very elaborately all their topics. And we have, personally, I have learned a lot from this because I am not a pediatric cardiologist, but still I learned a lot from their presentations. And thank you for all the panelists who have joined here. Dr. Abdul Salam, my friend, thank you very much for joining here. Dr. Abdul Shariar and Dr. Professor Muhammad Jahid Hussain. Thank you very much, and thank you all. Thank you very much.
Okay. Professor Fajula, Madam, where are you? Hello.
Naimo noy naki.
Okay, anybody?
অমিতাভ স্যারকে দিয়ে শেষ করে দিন।
No, it's okay. Dr. Ashok Datta was there, and now I'm not getting anybody.
অমিতাভ
Any
স্যারকে দিয়ে
comments
শেষ
from?
করে দেন স্যার।
Yeah.
Sir, thank you very much. Sir, thank you very much for organizing the webinar.
আমি একটু বাংলায় বলি আপনার কথা যে এত ভালো লেগেছে আপনার ইন কম্বিনেশন অফ সাম কমন পয়েন্টস অফ বেঙ্গল। আমি মনে করি যে আপনার ওই প্রেজেন্টেশন না খালি কেস না, কেসের সাথে যে কমপ্লিকেশনগুলো তার থেকে যে উঠে আসা, এইগুলাই কিন্তু শেখার ব্যাপার। আমরা ওই যেটা বলছেন সালাম ভাই, যে আমরা কেস করি, আমরা কমপ্লিকেশনগুলা রিলেটিভলি কম দেখাচ্ছি, যে আমার প্রবলেমটা আমি যে সলভ করতে পারি নাই সেটাও কিন্তু একটা শেখার ব্যাপার, সেইগুলাই শিখতে হবে আগে। সেক্ষেত্রে আমার মনে হয় যে আপনার প্রেজেন্টেশনটা ওয়াজ ভেরি গুড, এবং এইরকম প্রেজেন্টেশনই আমাদের মাঝে মাঝে দরকার, এবং যেটা আমরা বলতে পারি। থ্যাংক ইউ ভেরি মাচ। প্লিজ কমেন্ট সামথিং অ্যাবাউট আস।
অনেক ধন্যবাদ স্যার, থ্যাংক ইউ ভেরি মাচ।
Okay, we conclude the same just now. Okay, thank you very much. Okay,
Thank you, sir. Assalamu alaikum.
Thank you. Wa alaikum assalam.